the purpose of this talk, so I've delivered a part of this, or I've delivered a much bigger talk before in the past, and I realized, I had, I provided the info, I defined it, I provided the information, the background, the management, and it was 100 slides. It was way too much information. I probably overwhelmed the audience. And so what I wanted to do was take a step back, because I think Dr. Withy summarized it well, was that just kind of getting the point across today is my goal is, to what extent actually is this condition present in our patients that are experiencing anxiety or depression, or maybe cognitive symptoms like inattention or fatigue, symptoms that we regularly deal with in our profession. And almost every patient that comes in, we regularly see them if they're coming in with some sort of psychiatric related concern. And so I decided to call it the new imitator, because it's like, over the course of history, we've had a number of great imitators, whether it was Lyme disease or that was syphilis. And there have been a variety of other things. And what we came to realize in all of those instances was that we realized that these are conditions that we had to rule out, not actually try and look for before we tried to rule them in. And the reason being was because they oftentimes have a systemic effect on the body. And so there's such a constellation of symptoms, it's hard to really pin it down. But I'm hoping today that, after this talk, this is something that goes on your differential as you see these individuals coming into your office and they have maybe some sort of mental health related presentation. So no financial disclosures. So my objectives today are to talk about obstructive sleep apnea specifically, and how it commonly presents with or as psychiatric symptoms, how OSA occurs in all age groups and both sexes. So it's not just the stereotype of the older obese male. But also treatment of OSA, understanding that treatment of OSA will improve psychiatric outcomes and quality of life. So we're not going to go into exactly how to treat. That would probably be more advanced lecture in another one if there's an opportunity, but to understand there's benefit. So defining it. So basically it refers to an obstruction of the upper airway, and that obstruction essentially will cause an arousal, and that arousal can be conscious or unconscious. So a lot of people come in and they say, well, I don't really wake up in the middle of the night. You don't actually have to be aware of it. We're not referring to the awakening that occurs when, you open your eyes, you can't fall back asleep, or you have to use the bathroom and several minutes go by. We're talking about arousals that can be occurring on the order of seconds. And so your brain becomes awake and you may not even recall these are occurring. And during these episodes, during an obstructive process, basically leads to oxygen desaturation, hypercapnia, and sleep fragmentation. And the other thing that I didn't put in here is you also get your heart rate accelerates. And that's important because what that heart rate acceleration is showing is basically there's a sympathetic surge that's going on. And so the sleep becomes fragmented. And the way they test for airflow to differentiate between an apnea or hypopnea is during the test, they'll basically place a little indicator by your nose, and they're looking for the flow of air. And then so if it's completely stops, that's an apneic event. If it's reduced flow, it's a hypopneic event. So in terms of locations of where, sleep apnea can occur, there's a variety of locations. You want to look at, it's not just the scenario of, you may be aware that it may be an enlarged neck, and so it's the adipose tissues that's constricting the airway. But sleep apnea, it's anywhere through the airway passage can cause it. So we're talking right away, beginning right at the nose, so the nares, extending into the nasal cavity. When you think about the turbinates of the nose, and they can be hypertrophied, or maybe there's mucus or you have bad allergies, to the pharynx, if there's abnormalities with the structures, or you have enlarged adenoids, to the oral cavity as you're thinking the tonsils are getting narrow, or the tongue could be falling back, or it could be that the jaw is not of adequate size. So there's numerous things, or you could be a smoker, and or as we age, the walls, just like the muscles in our arms or our legs, the walls, the musculature in our airway weakens, and that actually increases the collapsibility or the tendency for that airway to fall on itself. And so these are just some examples, as I'd mentioned. You can have an enlarged inferior turbinate or some tonsils being enlarged, or, a tongue falling back to the back of the airway. And so folks who use that mouthpiece that they sleep with, that oral appliance, the job of that is to pull the mandible forward so as to prevent the tongue from collapsing on the airway. And so the science behind it is pretty simple when you're trying to figure out, what is the idea, what's the goal in sleep apnea? And so the problem is, long story short, is you have a pipe that's getting narrow. And the reason it's so significant, if you look at the formula for the area of a circle, it's pi r squared, meaning for every change in a millimeter, there's a quadratic or an exponential effect on the actual amount of air that's moving through. So reduction in 2 to 3 millimeters is a substantial reduction in airflow that's happening to that person. And that's why, so the reverse is also true. That's why small changes in opening up that airway or strengthening the musculature or whatever means you use can actually have a big impact on that person. So looking at the prevalence. So the Wisconsin sleep study found that in adults, 30 to 40 or 30 to 50 roughly, about a tenth of men and about 3% of women have at least moderate OSA. Mind you, that doesn't include mild, which is clinically significant when you're looking at psychiatric presentations, by the way. And then 50 to 70%, 50 to 70-year-olds, that number almost doubles or triples. In the case of men, it nearly doubles. In the case of women, that number triples. And they go on to say that's estimated that basically virtually most people who have sleep apnea are undiagnosed at this time in the US. And so gives you an understanding to the extent at which this condition, this great imitator is going undetected. And that's why I think it's the new imitator. So looking at it, OSA in non-obese adults. So, removing that factor, that confounder that says, well, it's obesity that's causing this sleep apnea with people with serious mental illnesses. And they look at a cohort of individuals with a BMI of about 25, 26, that borderline, maybe a little overweight, but some of them were normal weight. And they found out that, 25%, a quarter of nearly 500,000 participants who were evaluated, they found in the clinical studies, they found, quarter of them with serious mental illness had sleep apnea. If you look at it more specifically in terms of depression, that number went to 1 in 3. If you went to bipolar or schizophrenia, a number dropped a little bit, but still significant amounts. And then again, if you look at not just the clinical studies, but you look at the population cohort studies, they're again finding significant fractions of patients, serious mental illness, 11%, about a tenth of the population, major depression, double that. So when we have a person who's showing up depressed in the office, it's something to really consider on the radar. Looking at it in children, as a child psychiatrist, this is the part that pertains to a lot of my work. The general population of kids, about a fifth of them are known to have OSA of some type. But what's interesting is children with syndromic conditions. Think about your autism, your genetic mutations, kids with intellectual disabilities for a variety of reasons, 50 to 100%. So how are you helping that kid with their outbursts, with their tantrums, their low frustration tolerance, with their inability to grasp information, if every single night they're having difficulty breathing and they start off on the wrong foot? And so they go on to find is that, even genetics, as they went to go look into it, and they've done twin sibling studies, they've recognized that there is actually a strong genetic influence. So when taking a family history, as a provider, it's important. I often ask families, does someone have sleep apnea, the mom or the dad, or maybe the grandparents or an uncle? And then the other thing to ask is, because they may say, oh, well, maybe we don't have sleep apnea. Ask, is anyone snoring? And when I ask that, almost all the parents, or a lot of them, for these kids that are showing up tired, are showing that there's at least one parent who has a pretty bad case of it. And when they actually looked at the genetic studies or the twin studies, they found that in depression, about 95% of the cases of sleep apnea, there's a covariation between sleep apnea and depression in about 95% of the cases. Whereas in anxiety, there's a smaller extent, but it's still significant. About half of the cases can be explained by genetic influence. The other half due to some sort of environmental phenomena. And then look at externalizing behaviors, about just over half. And so as we think about the kids who act out, the oppositional defiance, the kid that's getting branded as the antisocial, the kid who's going on to use the substances, the kid that's having a hard time staying awake, and then they're having tantrums, what is it that we could be missing? And so looking at some of the data for depression and anxiety. So in 2020, it did a meta-analysis about 9 controlled trials, clinical trials with 1,000 patients. And they found that, if you, the pool standard mean difference for depression was 0.31. Now, if you put that in perspective, that's the same effect size as an antidepressant. And so now when you take your population of patients who have depression and they come into your office, if you know that you have this one medicine that you've developed comfort prescribing, your Prozac, your Zoloft, or what have you, and about 1 in 3 folks are probably going to benefit from that, and then about 2/3 probably, or about, you're going to have a significant impact for about 1/3 of them taking it. Now what you have here is you have another option where something can have a significant impact on mood for these folks, and that's not related to the medicine, meaning that if it's a multifactorial phenomenon, which you're going to find in many of your cases it is, as they don't respond to the medication, then here's another intervention that can be really beneficial for them. And of course, it's no surprise that they found that those who are most adherent to the treatment benefited, which goes on to directly demonstrate that using the device and addressing these airway obstructions and improving oxygen delivery, and then CO2 blow off, these things will lead to significant substantial improvements in one's mental cognition. In terms of looking at improvements, they actually have done studies, and when they were looking at the data, this kind of table just demonstrates for you, so you can appreciate that if you took a group of folks who had depression and they gave one group CPAP and one without CPAP, and you look at baseline depression, or the fraction of the population that remained depressed at baseline, if you look at the CPAP group within 3 months of use, and I would argue that it would probably have been even demonstrated that sooner than that based on the results I've seen, half of that population depression scores become non-clinically depressed. And then they find that it's a durable phenomenon, and it tends to trend down a little lower, actually, 12 months out. In the non-CPAP group, what they see is you see that persistence of depression. So as you look at that right column where it says no CPAP, just think about, those are the folks that are in your office that you try one medication with, 2 medications with, you do your individual psychotherapy, you maybe change the model to another therapist, and then you go on scratching your head, or there's frustration trying to figure out, why is it that this person is having such difficulty? And then they go on being labeled as treatment-resistant depression. And then maybe you have to start using antipsychotics. And now you have the concern of substantial weight gain in these folks, and maybe you only have a modest improvement in the mood. This is also, this graph kind of speaks to one of my points that I wanted to make today, was it's not just in men, it's also in women. And for you to see that. So in 2016, they did a clinical trial. They took 300 women, and they had moderate to severe OSA, and they randomized them to CPAP or conservative treatment for about 3 months. And look, if you look at the data, especially the first 2 points for depression and anxiety, the third point refers to sleepiness, and you're seeing massive treatment effect sizes. These things that are nearing basically 1. And so they have a substantial impact on the person. But if you look at kind of the 5th point on the physical end, and also with POMS, which is kind of just a global phenomenon of how someone's doing, both of these are showing huge effect sizes, and quality of life is what these people are reporting. And that's really an important thing, because so much of our work, for oftentimes, we're just trying to think, when patients have psychiatric symptoms, how do they cope? But that's not what individuals want. They don't just want to cope. They want to be able to thrive. How can they go on to not just live a life where they're feeling sad? How can they go on to live a life that they enjoy, and they have fun, and they can go on and do things and have hobbies and so forth? Suicidality. They looked at about 125 folks who were acutely suicidal with depression and no prior diagnosis, and they gave them a sleep study. And it turned out 1/5 of them were positive. And what they found was that daytime sleepiness or degree of insomnia did not predict sleep apnea. So just merely asking the person, hey, how sleepy are you? Or are you really sleepy right now? And then, do you have a hard time falling asleep? That wasn't necessarily a sufficient screening factor. And actually, this slide I wanted to use for that point, where having a mental illness, anxiety, depression, cognitive impairment, ADHD, these are all indications that are covered by insurance companies, and these are reasons for why you should order sleep studies. as that is actually the true presenting problem, which puts sleep apnea on the differential, not you having to investigate as to how sleepy they are. And they went on to found themselves, although there's the common pattern of the older obese male, but they also found a number of women with healthy BMIs. And that's also what we've been seeing in this clinic. Late life depression. And then so what they did in this study was they had about nearly 500 subjects of older adults. They were over 60 years old, and they gave them 300 milligrams of venlafaxine. And then after 12 weeks, they basically followed up with them. And they found out that 40% of them responded. But when you actually divide up the group and you take a closer look, most of the individuals that responded didn't have a case of sleep apnea. However, if they did, they noticed that response rate dropped from nearly, 4 out of 10 to just under 3 out of 10, which is a substantial fraction of patients. And now what the authors noted is bolded at the bottom, and they found that not only were fewer to respond, but they found that depressed older adults with OSA, they were more likely to have a longer episode of depression and have been exposed to more treatments. So again, I go back to that point is in your office, as you're dealing with that frustrating case, think about this as a possible option. Children, a similar phenomenon is the long story short. What they did in 2013, they did a meta-analysis and found 11 studies for kids with depressive symptoms and they were diagnosed with sleep apnea. And they found that there was a medium relationship. That's a huge effect size between depressive symptoms and sleep apnea. So in younger folks, they're finding that the impact of lost sleep is far more affecting on their mood than it is even with adults. And that makes sense. As we get older, we get a little bit better control as to how we feel and how we act out. Kids have a little bit harder challenge. And what they found was that in kids pre and post tonsillectomy, so now looking at a treatment for the sleep apnea, they found a medium improvement. That's a huge effect size. So this is the difference between a parent saying, I'm tearing my hair out, being like, things are now actually calm. We can work together. There's a little bit of moodiness, but now we can go on to setting up rules, setting up boundaries. How do we now layer in the therapies? And so that way my kid has the mental energy to understand them and respond and learn from them, and also at school, because now they've been actually sleeping and breathing well through the night. Cognition. They did a number, they looked at 19 studies, and they did look at that neuropsychological assessments in 19 studies. And what they found was that a small portion of them found no evidence of deficits, whereas a huge substantial number of studies actually did find deficits that occurred at a cognitive level. And these were studies that had a substantial number of per subjects, anywhere between 150 to 200 patients. And what they found was that the most common impairments were issues with working memory, executive function, and attention. And so this is really something important, because this is the patient that walks into your clinic with adult onset ADHD, and you're scratching your head being like, well, they're not exactly depressed. Are they anxious? Maybe a little bit, but it doesn't seem to be convincing. And they don't necessarily have childhood records, or even if they do, have they ever been evaluated for their sleep? And this is where you can see how mild cognitive impairment and ADHD can be considered maybe as the primary diagnosis, when in fact there could be actually a great imitator in place. And when they went on to do a variety of neuroimaging studies with different techniques, whether that was with nuclear scans or with magnetic resonance imaging, they found again that a number of structures correlating to where you'd have these impairments. The prefrontal cortex, the hippocampus, and striatum were all impaired in all these studies. And what they did identify was that persistent and recurrent cerebral hypoxia has been postulated to be the culprit, which really is of no surprise as you put the pieces together. When you look at elderly with severe OSA, here's one thing that they found was that these are individuals that were 75 years old. Okay, so much older cohort. And this is a severe sleep apnea. They have an AHI over 30. And what did they find? Look at the anxiety in red. Look how much that dropped. How many of you have taken care of an older patient and they seem anxious? And how distressing that is. And what is it that you have to use in the techniques? Well, we did notice that the neurocognitive test, the effect size was smaller, significant, 0.2, but smaller, which we can appreciate as the brain has had more years of, maybe if it was sleep apnea, recurrent cerebral hypoxia or whatever, it's degenerated further. but look at the benefit that can have on their tendency to worry, on their depression. Look at the quality of life. And that's a common discussion we have with an older population, is discussion becomes quality of life. Look at the effect size of this intervention on quality of life for these individuals. Sleep improves for elderly with moderate OSA. So what they found was that with moderate but not severe, with a group that's 75 years old, then they didn't know as much cognitive or anxiety or depression benefits. But what they did notice was that there was a huge, still substantial improvements in quality of life for the nocturnal symptoms and their sleepiness. So imagine what that means in terms of participating in your daytime activities for someone, or being able to sleep through the night if you constantly have disruptive sleep night in and night out. And so what's the importance of this? Is that if someone has moderate sleep apnea and you wait till by the time they get much older, that's not when they're going to have the huge benefit. Intervene early. That's the time to check. Looking at neurodevelopmental disorders in youth, there was 15 studies where they basically found there was some sort of impairment detected. And this was in all age groups, whether you looked at toddlers 3 to 5, you looked at children that were aged 5 to 12, or you're looking at adolescents. And they had about 260 subjects in there. And in all of these cohorts of children, they were finding that cognitive impairments in behavioral and educational aspects of them were consistently common findings in kids who had OSA. And when they kind of dialed in with the neuropsychological assessment, they would find phonological processing, visual attention required for intellectual development. These were common impairments. Phonological processing, they can get masked as a learning disorder. Visual attention, that's our ability to stay on track. And so this can get masked as ADHD, or that can compound into a learning disorder. Childhood ADHD. When they did a meta-analysis and they took hundreds of children across several studies and they put them together, they looked at the subjective item questionnaires from the parents largely, and they said, what was a common finding with them? And they found there was an overwhelming amount of more sleep disordered breathing that was going on with these kids. There's a greater suspicion from that coming from the parents. And then they also had more daytime sleepiness, but not as much as sleep disordered breathing. So what that would mean is, does your child make a sound when they're breathing at night? Can you hear them? Are they kind of restless? Does it seem like they have a dry mouth because they're mouth breathing so much and they can't breathe through their nose? When they looked at objective parameters, so they hooked up these kids to sleep studies, look at the results. They're huge. Higher sleep, higher AHI index, more events of not breathing through the night, less sleep efficiency. So they're not squeezing out as much juice as they can when they do go to sleep. They're not sleeping as long, and they took much longer to fall asleep. How many parents do you know pull their hair out that you know even personally with younger children and troubles around sleep? And the big thing that I also want to point out is, look how much stronger or powerful the results are on the objective parameters compared to the subjective. So what that should tell you is to have a low threshold, because just simply questionnaires or asking or going based on observation is going to leave you identifying a lot of false. You're going to have you're going to miss a lot of cases. And so you're going to have a lot of false negatives by you just going based on interviewing only. There was the CHAT trial, childhood adenotonsillectomy trial. Some may know this, in 2013. It took several hundred kids with sleep apnea, and they were young, ages 5 to 9, and they randomized them. Either you get your tonsils, your adenoids taken out, or you don't. What they found after a year was that they didn't find a neuropsych testing necessarily results to improve. But what they did finding was that there were substantial improvements in behavior, quality of life, and polysomnogram findings. And what's interesting is that the authors wrote in their discussion, though the neuropsych testing didn't improve, they felt that when they spoke to the parents, they saw improvements in attention and executive functioning. And so that actually led to a lot of the frustrations they were dealing with their child not having attention at home, or being able to stay on track or address certain things. If you actually ask many providers who actually treat the sleep apnea in the trial, they will tell you consistently that they are using lower doses of stimulant that's being required to treat it, because you're not compensating for sleepiness with the stimulant anymore. And what's the other benefit is, I have come to find that fewer kids tend to have side effects from the stimulant because they're using lower doses. And the cases that are being treated for sleep apnea and resolve, they're not going on to needing a stimulant. So oftentimes those cases, which aren't true cases of ADHD, they're the ones who tend to have the most side effects. Autism spectrum disorder. They looked at several hundred preschoolers in Japan, and they found that the preschoolers with autism compared to those who didn't have it had more sleep problems, including sleep apnea and parasomnias. And not only that, but the ones with sleep problems had more behavioral problems, no surprise. And then they found that those who had sleep problems were significantly correlated, or sorry, they found that the severity of the sleep problem was correlated with the behavioral issue. So the bigger the problem it is at nighttime, the bigger of the problem it is going to be at daytime, long story short. And this is the autism community. Oftentimes we're thinking about, well, what can we do in terms of the community? How can we change the structure? How can we make sure that they get a program that helps them with, some sort of vocational therapy or some sort of ABA, and so they can have some sort of analysis. How many times are we taking a look at their sleep? And it goes to show right here in the red boxes, this is that study with the Japanese children. What they found was that if you look at OSA and the odds ratio, it's got a 2.34 versus look at insufficient sleep, 0.87. So what is that saying? If you're the parent or you're the provider saying, hey, how many hours does your kid sleep? That is actually not the phenomenon that's highly associated with sleep apnea or these daytime behaviors. It's actually them not breathing well. And then what they found was that they did another study where they looked at kids with autism this time. And they found them, they took half of them who had OSA and half of them who didn't, and they performed adenotonsillectomies. And they found out that it was those who specifically had sleep apnea who had an adenotonsillectomy, they had specific improvements in the behavior, meaning that this is a specific treatment for a specific condition. Intellectual disabilities, a group that we may often overlook as we're trying to focus on other aspects of their care. But what they found was that they had about 40 patients with intellectual disability. And they found that if you actually put them in an intensive program where they learn to use the CPAP machine on a regular basis, they were actually, the providers were surprised to find, and many families as well, that about 3/4 of the kids and actually adults will actually go on to use the CPAP, which is a substantial number. And they will go on to use it at an acceptable level. In the case of this study, it was at least 4 hours a night, most nights, 70% of them. And what they found was the AHI in these kids, about AHI of 40, severe sleep apnea dropping to 5 after the course of just 2 months of adherence. And then that maintained after 4 months and also after 8 months. And what did they see? Improvement. Some of the biggest improvements were improvements in the most restrictive report complained. That was complained by the parent or the provider. Difficulty waking up, handling the individual, presence of irritability, sleepiness. These are all the things that we tear our hair out over when someone with intellectual disability comes in and we're trying to find ways to help them with their behavior. And they looked at Down syndrome. And this is actually a really nice table. And if you look at it, and if you basically look at someone who has an AHI of 1 or higher, and if you look at a child, an AHI of 1 or higher is considered positive for sleep apnea. AHI of 5 or higher is considered positive for sleep apnea in adults. If you take an adult with Down syndrome, half of them have sleep apnea. If you now take children with Down syndrome, almost all of them, 3/4 of them have sleep apnea. And so it's a very common occurring phenomenon. And we know that because they have small jaws and so they have large tongues. You basically have a recipe for disaster, including the airway. Look at other genetic syndromes, whether there's Down syndromes or mucopolysaccharidosis with young kids. They randomized them to both CPAP or removing the tonsils and adenoids. And what did they find? That the results were roughly similar. And so you were going to have substantial improvement in their sleepiness, their behavior, quality of life. And what they did find, though, the CPAP provided faster results. And that provides grounds for an argument to say, hey, if it's going to take me 6 to 9 months to get an adenotonsillectomy, what is considered a short-term solution as this parent is struggling, this family is struggling with this individual, and helping them, something that has minimal side effects to see if they can tolerate this. So That kind of summarizes the data, and kind of my take-home points for you is that I want you to recognize, in the same way Lyme disease was once considered the great imitator, but our widespread testing and our tendency to screen for it has now allowed us to respond faster and sooner and treat more cases of Lyme disease more effectively, to do the same thing with sleep apnea, and to understand that it can commonly present as psychiatric symptoms. We've seen anxious symptoms, depressive symptoms, cognitive impairment, all associated with it. It's a reversible cause of these psychiatric symptoms. How often do we struggle with that? Oftentimes with our medications, we're not able to reverse the course of the condition. We're able to really just kind of, put a lid on things. And these individuals are not necessarily obese. They're not necessarily males, they're females, young people, and patients with neurodevelopmental disorders are all cohorts at risk of sleep apnea. And so when you're thinking about making a sleep referral, oftentimes, sometimes on that form, what I've noticed at a lot of hospitals and a lot of places that send sleep referrals, they don't actually include mental or psychiatric symptoms on that list. So when the provider looks at it, they think there's no indication to send the child or the adult. But know that insurance companies, and I know this for sure because I've sent numerous, including HMSA, they will cover it if you write on that form the indication is for some mental health related reason. And you can even put fatigue, anxiety, depression, ADHD, intellectual disabilities, mental illness. They're all reasons. And be sure to consider referring early. So if you see it positive, or there's any concerns for the sleep, or they're presenting with these symptoms on the intake, now's the time to start it, knowing that this process can take several months before the family gets an appointment, and a couple more months before you get the report. So with that, I just wanted to summarize, that was my presentation. I'd like to make sure there's time to answer questions. And I also do have a case. If someone else has a case in the audience, I'd love to address that. Otherwise, I can present one for you.
I'm ready to go out and buy CPAP machines for my whole family. So message heard loud and clear. But they're pretty big and bulky. Is it something you have to talk people into? Especially kids, they don't want a whole mask thing.
Yeah, it depends, is what we've seen is, so when you're dealing with, probably the most challenging group is teenagers, because now they have a little more autonomy, and if they're anxious, they're a little more restricted. But this is why you work with the sleep centers, and it's important to not just get the CPAP or with the intervention, what have you, but you have them follow up for adherence. And so, you'll come to learn a lot of that just through practice over time, in the same way providers have come to, become comfortable writing for a Prozac or a Zoloft. But as they've kind of seen it and they've done it and they've played it out, but you'll realize certain masks are better fits for certain individuals. So, if it's a teenager, actually the easiest thing for an anxious person who feels claustrophobic wearing a mask is don't put it on at night. Put it on during the daytime and watch a movie. And get desensitized to it, right? It's very easy to do. And as you get comfortable with it, then you can go to sleep at night. You can go ahead and put it on, right? And then there's other features they can do where we're having folks kind of clean out their nose, so their nasal respiratory passage is working better. They could use an oral appliance, so it brings the jaw forward. If it's a teenager who's used to wearing oral appliances, maybe they want that instead. So there's a whole diversity. There's the massive range of options available. For young children, actually, you can perform physical therapy of the mouth muscles, and the tongue actually applies 200 times the force that braces do, and it will reorganize all of the teeth, so that way they're not only aligned, but it'll actually open up the airways, and in most cases resolve the entire case of sleep apnea. And you just save the parents braces, and only thing you need the parents to do is get on that kid to do this exercise, basic exercises, for 5 to 10 minutes 3 times a day. So this is a huge field with a very deep rabbit hole that it goes down. And so I'd love to come back and share. But my goal is to understand that this is actually, there are a lot of different specialties working on this, and we are actually operating in a silo, that side that's focusing on the mental health aspect. And we need to get out of that silo and join that huge cohort.
So what about the device? Can they wear the device at night? Does it help as much as the CPAP? Because I saw an article that said it didn't really help as much.
It actually depends. So if you're looking at kind of the cutting edge, right now, because they've realized that there's so many different interventions, and in that one of those earlier slides, there's so many obstructions that can take place from the tip of your nose or from your lips all the way through to your airway, the back of your airway. What you'll realize is that depending on the location of the obstruction determines the intervention you use, which makes sense, right? If you have a nasal passage problem and you have turbinate nasal hypertrophy, what's the point of me putting you on a device that pulls your mandible and your tongue forward, right? But what if you have both of those issues? And oftentimes people with severe sleep apnea, that's what they are usually a case of. It's not that they have a neck that's so large that it just causes them to breathe horribly. Usually what it is, it's 2 or 3 obstructions. And that's why the CPAP will usually bring it down by half, and you usually need like a second or a third one because it's a multifactorial problem.
And they can find all that on the sleep study?
You can find, so you can't find the location of the obstructions. You can find that the problem exists. And that's why what the leaders are kind of doing in this field is they're now performing something called sleep endoscopies.
Ah,
We are hoping so much that, ENT, there's going to be ENT providers that are interested in performing here. They're doing them in Stanford, they're doing them at Harvard, they're doing them in California. And what they do is just put you under light sleep, not heavy sedation, and they're actually trying to find the physical obstruction. And then they will zone in and say, here's the right treatment. What we're still doing is kind of, you could say, one step behind because we don't have that. So we're looking at what are the most common locations for obstructions? What are the easy ones we can find? We can send them to ENT. They can look at the nasal passage. They can look at the tonsils, the adenoids, go after and remove those things. So we can get a lot of the low hanging fruit. In the more complex cases, it might be a little bit more of a trial and error process.
and we have a couple questions about the exercises. Do you have to go to physical therapy to do that?
So these are usually speech language pathologists that do it, but they're trained specifically in this. So you can't go to any SLP. So the one on island that we use, brilliant group. Trini Murphy leads them up. They're called Intake or Speech Solutions, I believe, Speech Solutions. And so brilliant group, and young kids just have such an awesome response. And, in the beginning, the parents are kind of on the fence. So there is a process where they're seeing is believing, because the parents coming in, they're like, we just wanted a medicine and want this kid to behave better, or maybe there's a therapy, because that's what the gold standard is. So that's what we come to expect. And there's so when you kind of present this out there, they're kind of a little bit on the fence, and gradually moving them through it. It's a process. It could take several appointments just to get them on board as you're joining with them and for them to really buy into it, and then over time, as they do, and they start seeing the kid do it and they see the results, that's how it starts spreading. And it's at the point that the clinic now actually operates with speech solutions. They've set up a mini clinic within the clinic here, so that way we can get it convenient for these parents. And so all the keikis are moving through.
Yeah, this is just amazing, because at one point you said, I think 25% of people with depression, anxiety end up having some kind of sleep obstruction.
1/3 for depression, 25% across all mental illnesses.
So is there a, let's see, is there a, I'm trying to read this one. Is there a threshold for hours of sleep at night that would make you suspicious for this?
No, there's the only thing that I'm concerned about is the mental. That's why I want to present a sleep apnea and psychiatry. Go for the symptoms, because what we've kind of done is we've kind of taken I feel like when throughout psychiatry, there's been kind of this dichotomy, and you're trying to figure out where do psychiatric symptoms kind of present themselves in this new context of us being all brain focused now. And we're trying to figure out, is it in the mind? We have all these diagnoses in the DSM and for an anxiety disorders, a mental depressive disorder, but they're all syndromes. They're not diseases. There is no etiology identified for any of them. And this is the thing to keep in mind, is that if you have someone who walks in your office and say, I get anxious, and at times I really do struggle with my mood, and, I get very socially uncomfortable, and I'm noticing that's hard for me to pay attention. Well, what organ do they all have in common with? Right? In the same way, if a 50-year-old gentleman comes up and he's saying, I'm having chest pain and short of breath, do you give him your inhaler and a Tylenol? No, right? But that is the reflex that's been built, right? And that's the reflex we're getting out of, and we're realizing that almost 90% of the kids at this clinic are coming back positive.
Wow.
So we're talking a massive fraction of individuals. We're not talking about there's every other kid you're going to find. And in those kids that are actually negative, we're finding that's a gray area. I didn't go into this talk, but they're now identifying there's actually a huge fraction of individuals that don't meet the criteria for sleep apnea, but they actually have a sleep-related breathing disorder. And if you treat it, the psychiatric symptoms improve. And that's what we're seeing as well. So
Yeah.
if you actually include that as your threshold, the psychiatric symptom cohort would probably be way higher than 30%. It would probably be like 60 or 70%.
Wow. Do any of the kids grow out of the sleep apnea?
Some of them can. There's, as the airway matures, what they found in the chat trial was that a fraction of them do, because as your body grows, your airway matures. But here's one thing to keep in mind is that they noticed that over the course of a year. And whereas a substantial fraction still actually continued experiencing their symptoms. So the question is do you play a watch and wait with everyone? And then in the meantime, as they're stressing, you put them on antidepressants, antipsychotics, and antidepressants. If you look at all the sleep studies and you start looking at sleep literature, all of them fragment sleep. And they actually all advise to never give antidepressants at nighttime, when in fact, more often than not, before I learned that, I was telling most families take it at nighttime, unless it was like a Prozac. And so they know that it's notorious for worsening actually movements. It's notorious for worsening, fragmenting the sleep. And so it's a step in the right direction, but it's also a step backwards. And what do you do in the case where you actually have sleep apnea as the cause? And now you're not sure if they're depression, but you put them on 30 milligrams of fluoxetine. You want to keep them there. You don't want to just pull them off yet. And so you're now kind of stuck in a tough position.
So Renata says there's a researcher at NASA, I can't remember the name of the scientist, but he has a presentation that discusses other brain-related reasons for sleep apnea and SIDS.
Interesting. Yeah, I would love to see that.
Yeah. And Ella says, I nearly didn't marry my husband 30 years ago because he had a volatile temper and seemed wacky. I found he had sleep apnea and made him get tested and found out once he slept, he was the most mild-mannered guy you could imagine.
100%. And that's what we're seeing here is, you also, what's really interesting is you come in with the kid and the family comes in, you see the parent, and you're literally just watching the dad doze off as you're talking. And you see that genetic association. You see, 95% of folks with depression and sleep apnea have a genetic inheritance. That's huge. That's all of them. And you're talking to the parent, and sometimes it's not uncommon and oftentimes in psychiatry, we acknowledge that if you help the parent, or if the parent receives treatment, the child is known to do better. And so if that parent has really bad anxiety, we've found sleep apnea treatments tend to be really good for them. They can engage better. And you see that kids start responding as the messaging and the attention from that parent starts changing.
And Tammy asked if citalopram at bedtime can aggravate sleep apnea.
They say all SSRIs is what they found in the studies, that the point is that all SSRIs, SNRIs, the only two that don't seem to have, they impair slow wave sleep, REM sleep. They impair numerous stages of sleep. The only two that I haven't seen where it's not that they say it doesn't, but they just haven't found a huge amount of evidence to say that it does, have been Wellbutrin. And I wonder if that's because people take it in the morning, or maybe it's mechanism of action. And the other one is Remeron.
How about melatonin?
I haven't seen any studies on that, interestingly. There's so I that's actually, you know what, until you mentioned that right now, I haven't even thought about it. So I'll take a look. Well,
Renata gets credit for that. Ella says that some of the apparatuses are easier to adapt to as well.
100%. And here's the thing, when you look at a young person, but here's how we frame the situation, okay, especially when you have a young person, is that let's take the scenario of everyone's an adult here. Imagine yourself 2 years ago. How different was your health or your development 2 years ago? Probably wasn't significant, pandemic stuff aside. There's take a young person. How different is a young person in 1 year? So 1 year in an adult is more like 3 months in a child, if we're looking at developmental speed and we're not looking at chronological time. And so if you say, hey, I'm going to get this kid this sleep study, and then I'm going to go ahead, and then after I read the results, I'm then going to send them to ENT, then I'm going to let ENT send this kid through Flonase treatments for 6 to 8 weeks, and then I'll have them follow up. And then if they still don't meet that, we're going to schedule for surgery. You're at 9 months. How much development was lost in that brain and with that person in that time period? And so you really, so what we've broken it down into is that you have to look at it as short-term solutions. What are things we can start doing? What are medium-term solutions? We now have a positive sleep test. Should we really consider maybe a CPAP or something for the 6 to 8 months so you can get relief now as kid can start engaging in school, have a good school year? And then long-term solution, that kid's got enlarged turbinates or they have some adenoids that enlarge, get them into surgery, and now they have a cure. And that's the difference between those categories too. Which ones are curative versus which ones are dependent on? Yes, the children do stay at the sleep centers with the parents. Yeah, and they're amazing. You'd be surprised. We've had kids, you know, autism, severe intellectual disability, behavioral outbursts, and these sleep centers, the ones that are comfortable doing it, they'll be like, no problem. They're like, we have a sleep tech that's good for that. They don't take on these challenges if they don't think they can do it, and they can do a very good job. And so
Jason,
yeah.
Jason, could you also mention, kind of just talk about like airway hygiene and other techniques, kind of on the least invasive end of the spectrum?
Yeah. There's and so what we, as I briefly talked about the idea of having short, middle, and long-term solutions. So on the spectrum of short-term solutions that we use, what is something that you can do today? You came in my office, you're looking for something to start moving you in the right direction. Okay, I'm going to work with you on your sleep hygiene, of course, over the next 3 to 4 appointments. We're going to start chiseling that out on a week-to-week basis. Next thing, we do nasal hygiene. Okay, so what does that mean? How do we get that nasal passage moving 10 to 15% more air with every breath you take for those 6 to 8 hours you sleep at night? And so what can I do? I can wash out that nasal passage, sinus rinse. I can reduce the swelling. If I reduce the swelling, they'll Flonase nasal spray. 1 spray each nostril twice a day. So we have round the clock coverage for swelling. And then third thing, I'm going to go ahead and put a breathe right strip on you. Or maybe I'll use a nasal dilator if you can tolerate that a little easier. Most of these things you'll pick up at lung, so I'll put a prescription for some Flonase. And not only that, you now have that kid, you have the Flonase check mark now moving. So when it comes time to getting a positive sleep test and you get ready to send them to ENT, you've now cut out a 2-month waiting period.
And could you also mention like, what are your thoughts on wearable devices or tech that allows people to do kind of home oximetry?
So I find that it's, personally in my experience, I think it can be hit or miss. And the reason being is because it depends on the individual's ability to comprehend the data is what it comes down to. And so oftentimes those devices will summarize all that information into a very oversimplified scoring system. And they will be like, well, it says it's great, but I'm still having this issue. And that is where there's a gray zone. Where it can be really helpful is if they think it's bad and the device is saying it's bad, and that's encouraging them to change. And so it's usually sleep hygiene things being like, well, listen, you're going to bed at random times. Hey, listen, you're not getting the correct number of hours of sleep that you clearly need. So how is it that we change the things that you tend to have more control over? And so it can be a good behavioral element, and it's not really great for 1 night or 2 nights. It's good over longer terms. How am I as a sleeper? Not how was last night's sleep just specifically.
Other questions?
Yeah, just in response to Dr. Martin's question that he also posed, he says screening for food and environmental allergies can be high yield. Absolutely. The number of kids I've seen come in here, horrible allergies. I'm allergic to cats. Oh, what kind of pets do you have? I have 2 cats. Great. There's like, face is totally swollen and the kid's like super hyperactive, bouncing around, and you put them on and you literally just put them on Flonase and you're like, here, just have them wear this like strip. And the parents are like, wow, this is already a 50% improvement. Why not? Kid can't breathe.
And Renata says that when she stopped drinking milk, she got a lot better too. So
Yeah, they're notifying anything that reduces the diameter of that passage for air to move across. And if you notice that's causing inflammation in your body for one reason or another, or you have some sort of structural anomaly, or you have a small jaw, and there's a number of reasons for that. And then as a result, it's causing you mouth breathe, which compounds the smaller jaw. All of these things are going to basically lead to challenges. Thank you very much for having me. It was a real pleasure. And
Thank you.
Be friendly faces.
All right.
okay.
Good to see
All
you
right.
guys.